Now they are reversible inhibitors of MAO. Reversible inhibitors. So inhibition of MAO, monoamine oxidase A, selectively and irreversibly. Because of its reversible and short action, it doesn't exhibit cheese reaction. So cheese reaction तो नहीं होता है with the foods, but it can be used as an alternative to TCAs. तो TCAs क्या क्या थे? These these are the TCAs, amitriptyline and imipramine, right? Amitriptyline, oops, oops, amitriptyline and imipramide. So these are the TCAs that are, तो उसके ऑल्टरनेटिव में हम यूज करते हैं सेलेक्टिव जो MAO-B inhibitors है that we learned in uh, Parkinsonism. Yeah, selegiline inhibits only MAO inhibitors and it is useful in Parkinsonism. It is available as transdermal patch. Does a patch be available होता है in the treatment of? I'm just drawing it like patches जैसे होते हैं. Now reuptake inhibitors. तो क्या हो रहा है reuptake inhibitors में obviously SSRIs, SNRIs and TCAs they are involved. तो drug may inhibit the reuptake of both the serotonin and non-adrenaline. तो non-selective जो होते हैं reuptake. TCAs tricyclic antidepressants and only serotonin selective serotonin reuptake SSRIs selective serotonin reuptake inhibitors. तो हमने इस डायग्राम में देखा था reuptake किससे inhibit हो रहा है SNRIs SNRIs and TCN also SSRI. ठीक है तो नॉन सेलेक्टिव now non-selective reuptake inhibitors they are further divided into tricyclic antidepressant and serotonin. तो TCA तो था ही TCA जो हमने सेकेंड डायग्राम में देखा था and it was serotonin non-adrenaline reuptake inhibitors SNRI. ये दोनों में होता है लाइक Na and 5-HT दोनों में होता है जो हमने पीछे डायग्राम देखा था. ट्राईसाइक्लिक एंटीडिप्रेसेंट तो we are gonna do these drugs. So these are the drugs they act by inhibiting the reuptake of both serotonin and noradrenaline obviously. Now this results in increased concentration of these transmitters in non-adrenaline. तो क्या हो रहा है कि there is increased concentration of these transmitters and this results in increased concentration of in the synaptic cleft. Oh sorry गलत पढ़ लिया मैंने. तो synaptic cleft में serotonin और noradrenaline का concentration is increased. The bupropion also inhibit the dopamine reuptake. Bupropion. तो bupropion actually क्या था? It was actually increases presynaptic. Oops. Presynaptic release of catecholamine. Increase करता है and it was atypical antidepressant में आता है bupropion. तो क्या हो रहा है कि इट विल इनहिबिट द dopamine reuptake also, and ये then noradrenaline and serotonin initially they act on presynaptically act करते हैं इन दोनों रिसेप्टर्स पे. तो क्या हो रहा है कि and they decrease the firing of locus coeruleus. तो ब्रेन में जो locus coeruleus होता है they will decrease the firing. ये खुद में एक्ट करते हैं, they will decrease the firing because increase हो गया है मतलब साइनाप्स में इनका concentration is increased. तो locus coeruleus से they will feedback देंगे, तो locus coeruleus से there will be less firing and nucleus raphe magnus 5HT. ठीक है, locus coeruleus से Na प्रोड्यूस हो रहा है and nucleus raphe magnus से 5HT प्रोड्यूस हो रहा है. On long-term administration, desensitization of these receptors occur. तो receptor का desensitization होने के बाद enhanced transmission is seen. So this explains long latency, like 2 to 3 weeks of antidepressant action of TCN SSRIs, despite immediate inhibition. अगर हम immediately भी खत्म करते हैं, we discontinue the drugs, तो इसमें 2 to 3 weeks का latency period आता है because they are desensitized. तो उनको sensitize होने में टाइम लगता है. Let me just think about this particular thing for 2 minutes. हाँ, समझा मेरे को. So ये क्या बोल रहा है एक्चुअली कि जो इस डायग्राम में पता चलेगा. तो क्या हो रहा है कि प्री सिनेप्टिकली यहाँ पे Na and 5HT they are they bind to it, like they act on presynaptic alpha 2 and 5HT1 receptor. तो क्या होता है कि तो क्या होता है कि तो फायरिंग रुक जाती है. ठीक है, तो इफ वी आर तो इफ वी आर गिविंग द इनहिबिटर्स, अगर हम ट्राइसाइक्लिक एंटी डिप्रेसेंट दे रहे हैं, मतलब टीसी से तो नहीं होता है, बट अगर हम इनहिबिटर्स भी दे रहे हैं तो देयर विल बी लॉट ऑफ फायरिंग, नो, बिकॉज इनहिबिट कर रहे हैं हम, इनहिबिट कर रहे हैं प्रीसाइनेप्टिक, तो देयर विल बी लॉट ऑफ फायरिंग बिकॉज वी रिक्वायर इट, वी रिक्वायर इट. तो अगर हम बहुत टाइम तक एडमिनिस्टर करें तो डिसेंसिटाइजेशन हो जाता है रिसेप्टर्स का and there is enhanced transmission, like बहुत सारा Na and all वो सब प्रोड्यूस होता है. तो अगर हम ये रोक भी देंगे तो TCN SSRIs there is a reuptake inhibition, अगर हम ये reuptake inhibition अगर हम रोक भी तो 2 to 3 weeks के लिए लेटेंसी रहता है बिकॉज बिकॉज यहाँ से थोड़ा कंफ्यूजिंग है. Let me think about it. Let me think about it. काफी confusing है actually because DC is not even acting on those receptors. जिसकी ये बात कर रहा है please and तो sodium and serotonin ठीक है. They will act on H2 and 5-HT decrease करेंगे firing. ठीक है. तो बैलेंस में आ रहा है बेसिकली. अगर हम यहाँ से इंक्रीज कर रहे हैं NaOH हम इंक्रीज कर रहे हैं ये प्री सिनेप्टिकली एक्ट कर रहा है डिक्रीज द फायरिंग. तो ये बैलेंस कर रहा है. और लॉन्ग टर्म एडमिनिस्टर करेंगे तो सपोज बैलेंस हो रहा था. ठीक है. कंसंट्रेशन डिसेंसिटाइजेशन ऑफ दीज रिसेप्टर्स. ठीक है. अगर हमने लॉन्ग टर्म एडमिनिस्टर किया तो यहाँ पे जो जो पुरानी वाली डायग्राम है यहाँ पे रिएप्टिक हो रहा था सॉरी यहाँ पे बाइंडिंग हो रही थी लोकस एरेलियस न्यूक्लियस राफे मैग्नस. फायरिंग कम हो रही थी. बैलेंस हो रहा था सब कुछ. ठीक है. रिएप्टिक भी नहीं रुक रहा है. लाइक इट्स नॉट. नाउ हमने ड्रग स्टॉप कर दिया तो रिएप्टिक हो रहा है. रिएप्टिक हो रहा है और ये भी बाइंड कर रहे हैं और तो लोकस एरेलियस से जो फायरिंग डिक्रीज हो रही थी वो भी हो रही है. तो इन टोटो सोडियम क्यों बोल रही हूँ मैं इसको. Na and 5-HT they should be decreased. Antidepressant action. So we have to increase the now. तो antidepressant action कैसे हुआ इसका. समझ नहीं आ. इतना पता है बस amitriptyline और imipramide TCA देखना पड़ेगा. ठीक है. Guys, I think I'll explain you later or if you understood it तो comment section में मेरे को बता देना. Sedative action होता है clomipramine particularly मैप्रोटिलीन एंड ब्यूप्रोपियोन. ये सारे टीसी कहाँ हैं. and then if they are not talking about exactly TCs non-selective if they're not talking about the TCs तो मुझे नहीं पता what they are talking about. अगर इसमें ब्यूप्रोपियोन भी है तो I don't know what they are talking about. यहाँ पे सीजर थ्रेशोल्ड भी कम हो जाता है तो सीजर होगा. मतलब कम थ्रेशोल्ड में भी सीजर हो रहा है. वेट गेन तो है ही. वेट गेन होता है TCS के यूज से. एंड a powerful anticholinergic and weak alpha blocking property. तो anticholinergic होते हैं weak alpha blocking. अगर overdosage हो गया it's manifest in many mainly anticholinergic like delirium. There will be urinary retention, blurred vision will be there, constipation will be there. And these can also cause postural hypotension which is a problem. Cardiac arrhythmia. at toxic levels. Safety margin कम है. Amoxapine, they act as D2 receptor blocker and in addition to inhibition of Na uptake, reuptake. It possesses antipsychotic properties as well. And however, risk of the extrapyramidal symptoms and convulsions are also present. TCA imipramine are also indicated for nocturnal enuresis in children. However, the use is desmopressin. Oh, अगर रात, I think it just means रात को. If you have the urgency to micturate रात को. Nocturnal enuresis. Bedwetting, yeah. तो DOC is actually desmopressin, but imipramine भी दे सकते हैं हम. Bedwetting. Now, mechanism. Adverse effect. अगर presynaptic anti-uptake, neurotransmitter uptake, adverse effect क्या है? Tremors, insomnia. अगर inhibit किया तो cardiac fast sodium channels to conduction defects, arrhythmia, hypertension. पता है. Um, muscarinic acetylcholine receptors to hypothermia, flushing, mydriasis, all of the things that are required. Alpha-1 adrenergic receptor postural hypotension होगा. Adrenahistamine receptors, there will be sedation. Now poisoning हो गया तो क्या कर सकते हैं? Clinical presentation क्या होगी? Presenting signs of the TCA overdose include cardiac arrhythmia, hypotension, anticholinergic signs, hyperthermia, flushing, dilated pupils, intestinal ileus and urinary retention and sinus tachycardia. तो urinary retention तो बहुत जगह पे. urinary retention यहाँ पे था. Hmm. Now, central nervous system sign like confusion, delirium, hallucinations typically occur before the onset of the seizure or coma. Cardiotoxic effects are responsible for mortality. तो cardiotoxic effects होते हैं उससे person can die also. Now treatment part. Sorry. नहीं हुआ है अभी. Now IV sodium bicarbonate ये होगा. It is the single most effective intervention for the management of अगर cardiovascular toxicity हो गया, cardiovascular toxicity तो sodium bicarbonate दे सकते हैं. This agent can reverse QRS prolongation and ventricular arrhythmia. QRS prolongation रिवर्स कर सकता है, ventricular arrhythmia रिवर्स कर सकता है, hypertension रिवर्स कर सकता है. And intravenous sodium bicarbonate is a treatment of choice for sudden onset ventricular tachycardia and ventricular fibrillation or cardiac arrest. Now, lignocaine is a drug of choice for TCA-induced ventricular dysrhythmia. Lignocaine, however, care must be taken to avoid precipitation of seizure. Although हम sodium bicarbonate दे सकते हैं, lignocaine is actually a choice for TCA-induced ventricular dysrhythmia. And however, care must be taken to avoid precipitation of seizures भी हो सकते हैं. In comparison, many antiarrhythmic drugs should not be used with TCA overdose. तो antiarrhythmic drug हम नहीं यूज करते with the TCA because seizure होता है. Supranolol is, for example, depresses the myocardial contractility conduction, while prokinamide, disopyramide, and quinidine by a membrane stabilizing effect. So they actually stabilize the membrane, but जो propranolol होता है, it will depress the myocardial activity. So it may also enhance the tricyclic toxicity. Yeah, intravenous fluid. The preferred the preferred therapy in hypotensive patient intravenous fluid अगर है तो hypotensive patient में देते हैं. Dopamine can be used if needed because it has both inotropic and vasoconstrictor activity. Inotropic and vasoconstrictor activity है. On the other hand, sympathomimetic vasopressor agent carry the risk of precipitating tachyarrhythmias. Diazepam Diazepam is actually the drug of choice for the management of acute onset seizure. Obviously, phenytoin and barbital may be used as a second line drugs. Okay, and also physostigmine, the short acting anticholinesterase inhibitor. Sorry, cholinesterase inhibitor. It can be referred to as antidote of TCA. Physostigmine. Physostigmine antidote है. Physostigmine क्योंकि ऑल्सो लाइक इसमें थोड़ा एंटीकोलिनर्जिक एक्शन होता है तो cholinesterase inhibitor. तो cholinergic action will be increased because of its ability to increase the cholinergic tone and reverse the anticholinergic. Yeah, by it can however cause severe bradycardia, seizure, asystole by overcompensating for. अगर हम overcompensate करेंगे तो ये सब हो सकता है. And suppressing the supraventricular and ventricular pacemaker. As a result, physostigmine should only be used in the patient with coma or those with a convulsion or arrhythmia resistant to standard therapy. तो कोमा पेशेंट में हम यूज कर सकते हैं physostigmine या फिर those who have actually convulsion or arrhythmia and they are also resistant to the standard therapy. Standard therapy हम नहीं दे पा रहे हैं तो हम physostigmine दे सकते हैं. तो that now serotonin non-adrenaline reuptake inhibitors. यार अच्छा भी. एक second, you can just read it. Just Need to check on something. So, so serotonin, non-adrenaline reuptake. तो इसमें क्या है scenarize there are actually non-selective reuptake inhibitors for both of these SNRIs दोनों में use होते हैं as we have seen in the diagram as well. SSRIs are only used in the 5-HT but SNRI they are used in both, and however these do not possess other properties of TCA like alpha blocking or anticholinergic antihistaminic. Therefore SNRI are much safer than TCA and are currently considered the drug of choice for severe depression. तो actually अगर severe depression है तो we use these. Okay, these include venlafaxine, desvenlafaxine, duloxetine, milnacipran, levomilnacipran, D-isomer also. And duloxetine is the longest acting SNRI अगर पूछा, which is the longest acting तो longest acting तो duloxetine, duloxetine. This is the drug of choice. This is the longest acting. Acts for the longest time. Milnacipran and duloxetine they are indicated in fibromyalgia. If somebody has fibromyalgia, तो तभी भी हम मिलनासिप्रान और ये देते हैं which is an SNRI. SNRI दे रहे हैं ना. Venlafaxine has a faster onset of action and minimum drug interaction. So it has the least like contraindication with other drugs, venlafaxine. So they are trying to say that duloxetine is indicated in neuropathic pain also. If somebody has neuropathic pain, fibromyalgia में milnacipran and duloxetine दोनों यूज कर सकते हैं. तो that